And let me just say that in this one slide, I'm not here today to tell you that these new anticoagulants, the target-specific oral anticoagulants, do not work. They work very well. They've been demonstrated to work very well. They're at least as effective, if not more effective, and as safe, if not more safe, than the standard therapy, warfarin therapy. And as you can see from this one slide, which is in your handout, this really summarizes all of the important findings in the three major AF trials, looking at the relative risk reduction for stroke or ischemic stroke, hemorrhagic stroke, major bleeds, etc. And those that are in pink are the ones that show a significant improvement. Those that are in blue show that they were actually significantly worse than warfarin, and those that are in gray show that there's no significant difference. So these drugs do work. But the details are really important to find out in terms of looking at these studies. And just as one example, so it's not, these are all highly regimented, organized, well-managed clinical trials, but maybe don't reflect the real world, and we'll talk a little bit more about that in a moment. But just as one example, when you delve into the trial, and this is the Dabigatran RELY trial, looking at the quality of INR control, and you can see from the top line, when INR control, or time in therapeutic range, is poor, that the new drugs work quite well and are significantly very much superior. But if you look at the bottom, when the time in therapeutic range is very good, and that's difficult, it's not easy to do that, it loses its efficacy at that point and really is just as good as warfarin. And so things like that, you have to look into the trials to see what some of the real details are. As they say, the devil are in the details. Now, I want to highlight 4 concerns with the new anticoagulants. And they are things like managing failure of therapy. And what we mean here is basically compliance or adherence to a drug regimen. Managing bleeding or the need for urgent surgery. Managing patient follow-up and monitoring, the whole issue of monitoring. And then managing the patient in general and perhaps unknown side effects or unknown effects of these drugs. And ultimately, we want to get to what or who is the appropriate or the ideal patient. And if we look at managing failure of therapy, which really we're talking about compliance or non-adherence, this is a recent review from Granger in the American Journal of Cardiology. And you can see that when they look at patients with heart failure, now this is not necessarily patients on warfarin, but just patients with heart failure in the cohort that they looked at, and tried to identify the reasons for not taking the drug, you can see what the various reasons were. 20% of the patients could not remember to take it on time. 16% felt that they were too expensive, too many medications, don't know the side effects, etc., etc. So there's real issues of non-compliance. And I must tell you a story that happened just this morning. I have an elevated cholesterol and I have mild hypertension, so I take a statin and I take an antihypertensive. So I'm getting up, I'm upstairs, I'm washing up this morning, and I get my little 7-day pill box, and I go to take my medicine. I happen to look at the Friday thing, and I look inside, and my pills are in there on Friday. And I said, oh my God, what did I do yesterday morning? Did I take my medicine or did I not take my medicine? It turns out I forgot to take it. And it's not anybody intends to be non-adherent. It just, it's a reality of life. And it happens to me, I must say, once a month I go, and fortunately I'm still alive today, but when you're talking about an anticoagulant that has a short half-life, this is perhaps a real issue. And if you forget a dose or if you forget 2 doses, what is the outcome going to be? And I don't think we really know that. Obviously, the compliance in the clinical trials was outstanding, but in real life, it may be a different feature. Also with RELY and with Dabigatran, there was about 11% incidence of dyspepsia, and this is a reason that patients may start their medicine and then stop it because of some stomach upset. And again, without telling their doctor and what are the side effects or consequences of that. If we look at dose frequency and compliance, again, from the Granger review, this is from 76 different studies looking at electronic monitoring that patients took most of the dose, 80% of patients took most of the doses if it was once daily, and only 70% took most of the doses if it's a twice daily medication. And you can see how it changes from there. And so with Dabigatran, it's a twice daily dosing. With apixaban, it's twice daily. With rivaroxaban, it's once daily. But these are factors that you have to take into consideration. If we look at issues of depression, even for those who are non-depressed, there's about a 15% or so incidence of taking less than 80% of the prescribed medication. And you can see where the numbers are when you're very depressed. And if you look at insurance, type of insurance and compliance, and again, even with good insurance, employer or other private types of insurance, from 10% all the way up to 30, 35% issues of non-compliance. So these are important issues. If we move on then to look at managing of bleeding or when patients are taking these drugs or urgent surgery needed, I can't really show you many slides on this because there's absolutely no significant or meaningful data out there as to what do you do if somebody has major bleeding with a drug or if they come in and they require urgent or emergent surgery. Now, yes, the drug wears off quickly, but again, if you had just taken your drug or you know, it's an hour afterwards, that may be a big issue. And there are some animal studies and there's some healthy human trials, volunteer studies looking at reversal of anticoagulation parameters, but there's no real systematic studies looking at how do you reverse these drugs. Most of us do recommend 3 or 4 factor PCCs or recombinant 7A, but there's really no good proof that this is going to work in these cases. So it's another question that is unanswered at this time. If we look at managing the patient and the follow-up and the issue of monitoring, this is just a theoretical scheme of drug levels. It's a whole different paradigm today with these new drugs. With warfarin, the goal was to get your INR up to between 2 and 3, and to have it stable 24/7, 365, and to keep it in that range. But with these drugs, there are peaks and troughs, peaks and troughs. This is, again, just a theoretical plot. And so if one wants to monitor a drug, when do you monitor it? Do you monitor it at a peak? Do you monitor it at a trough? You have to have the patient come in the morning or in the afternoon, depending on when they're taking it and so forth. But in fact, there is no need for monitoring it. But if you want to know what the drug activity is, if you have a major problem, again, that's an issue. There are no great monitoring assays available to tell us precisely how much drug is on board. So this still is a problem. How do we manage this clinical situation? And then lastly, if we look at just managing a patient in general and what are unknown effects, you know, we saw the results from these trials. You've seen the studies already, and I just want to highlight, I'm not going to go into detail, but just to keep in mind that there are a number of key exclusion criteria for patients who entered these trials. These are not real-world patients. Many of them are, but not all of them. They're not all the patients that we see in our practice. And so what does that mean when you release these drugs in the real world? And I don't know the answer to that, but it's a concern. And look what's happened. And I don't mean to pick on dabigatran, but it was the first horse out of the barn, so we have the most experience with dabigatran. And so, you know, we're looking at some of the issues. It's a great drug, but in fact, we have warnings from Australia, from Japan, from the FDA, from the American Geriatric Society over the last 2 years about increased bleeding complications. Well, are these more than what was seen in the trial or not? We really don't know that answer, but they are certainly coming to the fore, and there's certainly a concern, and they've required some change in labeling of these drugs as well. So, in summary, these new oral anticoagulants have great benefits, great potential. I am a big supporter of them, but I still have a number of questions as to how are they going to work in the real world. We have to be careful. Are these the first agents we turn to or not? They have a short half-life, which is a real important issue for drug adherence. There's no routine coagulation monitoring required. Well, that's great, but it also has a liability attached to it as well. If we do need to know the level, there are no good, I mean, in fact, the 10A assays for the 10A inhibitors works well, but not many hospitals have that readily available. There's no antidotes, and the cost, not the cost to society, but the out-of-pocket cost when you walk into a pharmacy and you have to hand a copay is a significant issue, and it makes patients either string out their medications or not purchase their medications, and that is a factor as well. So the take-home points for me, and I'm talking fast to try to stay on time here, is, and we'll just skip down to the third or fourth bullet, that the new anticoagulants have many favorable characteristics compared with warfarin, but some of these characteristics may actually be liabilities. The new anticoagulants may not necessarily be the drugs of choice for patients, the first drug of choice for patients with AF, and we still need to define who is the appropriate patient. I know Chris is going to talk about that, but I think there are real questions out there. There's still a lot of unknowns about these drugs. I think we need more data. We need a lot of post-marketing analysis of these agents.
I'm really happy to be here, but I'm not happy to be debating Jack Ansell, who I consider to be the kind of like the godfather of anticoagulation. You can't beat him. But I'll do my best. These are my disclosures. So my task is to convince you why these novel drugs should be the first choice for patients with atrial fibrillation. And we've already heard the data, which is a big help to me because I think it's been a fairly convincing display of the clinical data and the benefits of these novel agents, which we're using primarily to reduce stroke, in the context of doing that in a way where we don't cause too much serious bleeding. And I think we all recognize, and the points have been well made, that warfarin is a very good treatment, and it's a very effective treatment. And I'll just say this now, but I think our biggest responsibility is to make sure that all eligible patients are treated with an oral anticoagulant, including warfarin. And then which one is a question of secondary importance, but nonetheless is very important. I think that some of the concerns with the new agents are exaggerated, and the novel agents outperform warfarin in almost every important way based on our gold standard of assessment in the randomized trials, up to a 1/3 reduction in stroke, up to a 70% reduction in intracranial hemorrhage, a reduction in mortality. And in aggregate, it's a statistically significant reduction in all-cause mortality, which should give us a lot of confidence. And then I'll suggest that these are also consistent benefits regardless of INR control. And I won't go through anything about the trials other than to point out that originally these were designed as non-inferiority trials. The hope was to develop new treatments which were as effective as warfarin with much better convenience and to overcome some of the limitations of warfarin. And in fact, the landscape now has dramatically changed because these new agents have the distinct advantages. So how do the novel agents stack up against warfarin? This is the fact check. I hope I'll do a better job than the Republican convention. I'm not sure the Democratic convention did much better, but anyway, I'm in Massachusetts, as Alice reminds me. We can't compare one agent to another, and that's, I think, a hazardous thing to do. And there already have been publications by Greg Lipp and others trying to do that, but we need to be careful. But what we can do is put the results of the trials side by side and look for consistencies and differences. And I'll just show a couple of slides here. One is for the effect on stroke or systemic embolism versus warfarin with dabigatran, rivaroxaban, and apixaban. All of the drugs have a tendency for lower risk of stroke or systemic embolism. And then in 2 of the trials, a statistically significant reduction with dabigatran and apixaban. And then the most striking finding was this reduction in intracranial hemorrhage, with about a 50% reduction in intracranial hemorrhage compared to warfarin with each of the trials. And this highlights the fact that there seems to be a liability of warfarin. Warfarin is doing something specifically in the brain circulation that causes this risk of intracranial hemorrhage. And then again, mortality. Each of these trials, and this perhaps isn't surprising because about half of patients with intracranial hemorrhage die. Each of these drugs reduces intracranial hemorrhage. There is this about 10% reduction in mortality. It was statistically significant in the Aristotle trial with apixaban, but it's almost identical with the 3 drugs. And I think now this is a robust finding that there really is a reduction in all-cause mortality. Let me turn the tables here a little and say, if warfarin came along after the novel agents were already available, would it be approved by the FDA? Would this debate even have the opportunity to occur if the novel agents had come first? So this is what warfarin does compared to the novel agents. 10 to 50% increased risk of stroke, 2 to 3-fold times the rate of intracranial hemorrhage, as much as 1/3 higher rate of major bleeding, at least versus apixaban, requirement for monthly monitoring to adjust dose, falls out of the target anticoagulation range 1/3 of the time, even in highly controlled trials and in good anticoagulation environments, many food and drug interactions, and a 10% significant increase in all-cause mortality. So the answer is no, we would not be having this debate. Warfarin would never be approved if the new agents were already available for non-valvular atrial fibrillation. You've heard that in a system with good INR control, maybe the novel agents are less important, and you saw the data for dabigatran. Perhaps there was a tendency for less of a relative benefit for reducing stroke in the patients in centers that had excellent INR control in countries like Sweden, where there's 80% time in therapeutic range. And that in the other trials, in Rocket and in Aristotle, the odds ratios, the hazard ratios line up almost exactly regardless of time in therapeutic range. So the data really suggests that the benefits of these drugs are consistent across different centers according to the skillful use of warfarin. And then this is the most important, is regardless of the center's INR control, regardless of how good of a job people are doing with INR control, the reduction in intracranial hemorrhage is highly consistent. So intracranial hemorrhage is less related to time in therapeutic range. This may be partly because most of the time out of therapeutic range is below therapeutic range rather than above therapeutic range. I think that Dr. Ansell's strongest argument is this issue of adherence. And it is an important issue. That ways to improve adherence are to measure it. We do that on a monthly basis with warfarin, and to have regular interaction with healthcare providers and a lot of education. And those are inherent characteristics to warfarin. So it's a serious issue. And as we use these new agents, we really need to keep that in mind. But we also need to look, we wonder how will these new drugs behave in the, quote, real world, which I think is actually a little bit of a misnomer, because these large trials are highly representative of general practice. But what we know is we know how warfarin behaves in the real world. So this is how warfarin behaves at Mass General, with Elaine's publication in Circulation, looking at a group of patients who were over age 65, initiated on warfarin. Over the first year, 28% of patients stopped it. Major hemorrhage, 7%, 58% of the time in therapeutic range. Major hemorrhage, 20% for patients who were at high risk for stroke. Intracranial hemorrhage, 2.5%. So we already know that warfarin is a huge problem, and these new drugs in the trials have the substantial benefits. How about tolerability? This is a pretty remarkable finding, I think, about this class of drugs. This is for apixaban, but this is compared to aspirin, compared to low-dose aspirin. Over 2/3 of these patients were on either 81 or 162 milligrams of aspirin versus apixaban. Statistically significantly fewer patients stopped apixaban than stopped aspirin. How about this issue of no reversal agent? I think also this is a bit of a distraction, because the real way to deal with the most serious type of bleeding is to prevent it from happening to begin with. So which would you rather have, an intracranial hemorrhage on warfarin and then using fresh frozen plasma, vitamin K, prothrombin complex concentrate, activated factor 7, neurosurgery to reverse the event and still have a 50% mortality, or prevent the intracranial hemorrhage to begin with? I think it's pretty clear what the better strategy would be. And in fact, when we look at these agents, in this case, apixaban in the Averroes trial, comparing it to aspirin, small numbers, but nevertheless, there didn't even appear to be any increased risk of intracranial hemorrhage compared to aspirin, compared to low-dose aspirin. So these drugs really are quite safe with respect to the issue of intracranial hemorrhage. So in conclusion, then, these new agents are not perfect. But based on all the important features, stroke reduction, intracranial hemorrhage, major bleeding, tolerability, convenience, all-cause mortality, they are better. I think the only real reason to use warfarin as the drug of first choice is this cost issue, and that is a substantial issue. Although with Medicare Part D supplement, I think typically these new drugs, the monthly cost is in the range of $40 or so. And the novel agents, therefore, should generally be the initial drug of choice for atrial fibrillation. Thanks for your attention.
Thanks, Chris, and thanks, Jack. I'm going to ask you both to stay up here. It's a great debate, and I think no matter what side of the issue you fall on, one thing we can all agree on is we have more options now than ever before for stroke prevention and atrial fibrillation. That really poses an incredible challenge for those of us that see patients. How do we talk to our patients about the different agents that are available now? And how do you go about explaining to them the choices that they have and the benefits and relative limitations of the different drugs?
Well, I think that's a key question today, is trying to select the ideal patient and looking at new patients with these drugs. And I think it really depends on the characteristics of the patient. So not every patient is the same. And what are the risk factors associated with either bleeding or intracranial hemorrhage for that patient? Because I agree, the results of the studies are the results of the studies. I can't argue with them, they're very good. But my major point is that as the drugs come out, we're seeing some things, and I'm not quite sure why we're seeing some of these things, how the drug is being used, using dabigatran in patients with renal failure. All of this requires education, just as it does with warfarin. And so my concern is that everybody jumps on the bandwagon, in a sense, and uses the drugs inappropriately before we really know what are some of the major issues. So issues about how compliant or adherent or responsible, if you will, a patient is in terms of deciding what to use. And I think you have today, I think all of us agree that it really is a discussion with the patient and getting the patient's preferences. And some patients, in many cases, it is better to have a monitored drug than not to have one. So it's just not clear-cut. It's a tough argument for me, no doubt about that. But I'm just saying that one has to think, and I think the key is that we need a lot more information. We need the pharmaceutical companies and others to look at post-marketing outcomes of these drugs.
And I agree with that perspective. I will say, I think generally for the patient who's initiating on a drug for atrial fibrillation, that there's even a more compelling reason for the novel agents. That there is a liability in initiating warfarin. It takes months to get patients typically in the therapeutic range. I think another interesting question is for patients who've been perfectly stable on warfarin for years. Even there, I think there's a real benefit, including this lower risk of intracranial hemorrhage for the new agents. But that's a somewhat lower priority. I think most new patients should be placed on a new agent with the important caveats, Jack, that you point out. I think we need to be even more concerned about adherence, education, renal insufficiency being an important issue, especially with dabigatran, making sure that we have patients on the right dose.
Well, thank you very much. That was a wonderful debate.